Can I have my slide? Okay. In comparison of common flow procedures commonly used these days, transfer approach is getting popularized due to least surgical mobility and excellent post-operative cosmesis. Thyroid thyroidectomy can be classified into sublingual and vascular combined approach according to the incision site. The advantage of transvarsal approach is low invasiveness in creating working space compared to the other remote toxic thyroidectomy. And post-operative cosmesis is better than other procedures. Also, it enables surgeons to perform bilateral total thyroidectomy and complete central lock dissections. The indication include the benign tumor less than 4 centimeters and intermediate node of, benign 6, intermediate 4. And ideally, thyroid cancer is less than 2 centimeters. Size criteria is important if you take out the surgical specimen through the transvarsal incisions. Also, ideal patient, the female right side for right-handed man and no big goiter, no thyroiditis, no pronatic mandible. Contraindication definitely is case with gross extrathyroid extension cases. Also, relative indications in largely conglomerate lymph node metastasis, also substance goiter and with Graves' disease or severe thyroiditis cases. In comparison between robotic and versus endoscopic procedure, the robotic procedure provides high magnified three-dimensional view. Also, it enhances the surgical dexterity and ergonomics. Also, if you use that X-ray port, you can extract the surgical size of a specimen through the X-ray port. However, endoscopic procedure is a more cost-effective procedure. Also, it takes a shorter operating time. The surgical outcome of transoral thyroidectomy is similar to the conventional approach, except the operation time and post-operative cosmesis. In the comparison between robotic versus endoscopic procedures, the complication rate slightly lower in the robotic procedure compared to the endoscopic procedure. Especially the transient recurrent malposition rate is lower in the robotic procedure. Hypoparathyroidism is a common complication in thyroidectomy. It is very challenging to preserve parathyroid gland, also the intact blood supply. So the NIRAF and ISTS angiography merged as a new method to confirm and preserve the parathyroid gland and evaluate the perfusion and function of parathyroid glands. However, this ISTS angiography is not evaluated, its feasibility efficacy is not determined well in robotic and thyroidectomy. Also, the NIRAF autofluorescence is not available in robotic procedures. This slide shows a device for the angiography and the NIRAF in robotic and endoscopic thyroidectomy. So I evaluated feasibility of because as ISTS angiography in transfer robotic thyroidectomy, I evaluated 130 patients. As you can see here, the parathyroid identification rate about 95%. There is no difference between ISTS group and control groups. In total thyroidectomy cases, the incidence of hypoparathyroidism is about 27%. There is no big difference between the control and ISTS groups. We evaluated perfusion according to the status of ISTS perfusion. And as a result, I'm very disappointed result. The rate of well-preserved ISTS perfusion was just about 30%. And about 30% also not perfused one right face nerve. So we expected that we usually preserve the parathyroid gland, but the vascular supply is not preserved. We need to keep in mind. But getting familiar with this procedure, I feel that the preservation of parathyroid blood supply technique is getting improved. Yeah. So the total ICG perfusion score is correlated with the post-operative PTH levels. So it is feasible also to enhance surgeon's confidence in help dissect parathyroid gland and predict post-operative function using the ICG perfusion score. One of the methods is ICG angiography is mapping angiography during the procedure before the dissection of parathyroid gland. We can evaluate the vascular supply pattern. It is very helpful to preserve the parathyroid blood supply during the dissections. However, there are limitations. It is very subjective. There are no standardized system to determine the degree of ICG uptake. Also, there is no clear guideline regarding when parathyroid gland auto-transplantation should be performed. We don't know. We don't have an answer for that right now. Also, non-thyroid injury is one of the interesting complication. Actually, it is reported very high initial period of almost 100%. Also, it is very diverse instance may be related to the subjective evaluation of this mental injury. So I evaluate mental lobe and sensory loss in the children area using the monofilament test. As you can see that lower than children area innervated by mental lobe, there is no difference in terms of pressure threshold scores before and post-operatively. Actually, about 10% of patients complained of transient numbness the chin area post-operative 1 week, but after that, it recovered fully. So if you place the proper design, the instance of mental injuries should be very low. CO2 embolism also is a rare complication. The actual instance is very low. Actually, so far, 12 cases is reported in the literature, but actual incidence might be very, very high than reported. So usually occur during the procedure, creation working space due to the laceration of anterior vein. We need to be very cautious about that. If CO2 embolism occurs, CO2 gas should be stopped and 100% oxygen should be administered, and patient position should be changed. Hyperventilation is useful to help eliminate the CO2 gas. How about learning curve? The learning curve of transverse thyroidectomy using endoscopy is reported to around 50 cases. I also evaluate the transverse robotic thyroidectomy using learning curve. In my series, learning curve about 50 and 55 cases. It is difficult to determine exact the learning curve. It might be multiple steps, so we need to consider multiple steps of the learning curve. The second advantage of transfer approach is superior cosmesis. We evaluate cosmetic outcome after various types of remotoxin thyroidectomy. As you can see on the length analysis, transversal barbell linked first and second place. After that, followed by the transaxillary, followed by retroauricular, followed by media, and the last is the conventional approach. Another advantage of a transverse thyroidectomy is superior cosmetic, the voice outcome. As you can see here in my study, the voice handicap index lower in the transverse and preservation of highest frequency is better in transverse groups. Also, swallowing outcome I evaluated does not differ between the conventional and transverse approach groups, except post-operative 1 day. It might be related to the pain related to the oral incision, but after that, there's no difference. Also, oncologic outcome is important. I evaluated oncologic outcome during the follow-up of 5 years. There's no difference in recurrence and survival curves. Actually, also in a meta-analysis study, also there is no difference in oncological outcome between the various types of remote access thyroidectomy. In summary, transoral robotic thyroidectomy is feasible and comparable. However, there are unusual complications. Neuromonitoring and ICG angiography is effective to avoid nerve injury and hyperparathyroidism. Essential advantage are superior cosmesis and superior voice outcome. Oncological outcome are comparable. And however, the strict patient selection criteria and overcoming of the learning curve are very important. Thank you for your attention at times.